Welcome to this session on arterial circulation. The reason why we're going to talk about arterial circulation in terms of wounds is that insufficient arterial circulation causes tissue loss in terms of ischemia, so the lack of oxygen and nutrition to the tissue. This will first cause a wound and then complete loss of tissue. This is one of many reasons why a wound might develop, but we're going to focus on arterial circulation and the lack of arterial circulation in this session. This is an overview of the teaching goals. I would like for you to define an artery and the basic physiology or the basic buildup of arteries. Name some of the major arteries supplying the lower extremities and understand their importance in the circulation, especially in the lower leg and foot. We're also going to talk about the development of atherosclerosis and how this defines the development of arterial insufficiency. And we're also going to look at the clinical stages of atherosclerotic disease. We're going to mention the difference between a thrombus and an embolus. And we're going to look at diseases affecting the intimal layer of the arteries versus the medial layer. And finally, when should we suspect arterial insufficiency as a cause to the wound? The arteries are defined as vessels leaving the heart, meaning any vessel carrying blood that leaves the heart is named artery. Almost all arteries contain oxygenated blood, meaning that the hemoglobins are filled up with oxygen. The exception is the pulmonary artery to each lung from the heart to the lungs, carrying the deoxygenated blood, meaning hemoglobins filled with carbon dioxide. And this is because the arteries that go into the lungs, the pulmonary system, they are filled with blood from the venous system, so they use blood going back to the lungs to be replenished with oxygen. If we look at the walls of the arteries, we can see here that we have an inner layer called the tunica intima, and it consists of an endothelium or an inner layer of cells, and this intimal part and the endothelial layer we'll get back to when it comes to atherosclerosis, because this is where the atherosclerosis will attack. Then we have a middle part called the tunica media, and the tunica media has mostly muscle, smooth muscle cells, and a large part in the arteries. And finally, the external layer, the tunica externa, which is this outer part right here and is rarely affected in arterial disease. We're going to look at the arteries of the lower extremities and the blood supply of the thigh, the lower leg, and the foot. And we usually divide this into three sections or three levels. So the abdominal aorta, the systemic main circulation is here. This is the aorta. This is the thoracic aorta with the heart right here. And the abdominal aorta is defined as anything below the diaphragm. So this is where your diaphragm is going to be. And this abdominal aorta right here is going to divide into the iliacs right here on each side. And then you have the upper part of the leg, and then you have the lower part with the foot arcade. We're going to look into detail on these. So if we start, this is the abdominal aorta and also the divisions. So let's have a look. We start up here with the iliacs, and what happens is the abdominal aorta will divide right here into a common iliac artery. That's the first part, a left and a right, and it will give off a branch into the gluteal region, so into the pelvis area, called the internal iliac, and the external, so the other part, will continue. It's called the external iliac, and it will continue through the groin and change its name to femoral artery, so the common femoral artery. What happens if the internal iliacs are occluded is usually problems with the circulation to the pelvic area or the gluteal region. So the patient will complain about buttocks pain when they are in exercise. The next level is the thigh, and here we have two main arteries. The common femoral artery is going to divide, so let's look at the patient's right side. It's going to divide into a deep branch right here. This is the deep branch, and it's going to have a superficial branch right here, and the superficial is going to continue down towards the knee and divide or split into three arteries of the lower leg and supply the foot. So this is the last part, the receiving end of this blood supply, and that is three arteries of the lower leg and a foot arcade. I'm going to look into that. So here, if you look on the left side, this is the same thing that we just talked about, and you can follow from the abdominal aorta becomes the iliacs, and then you have, as we spoke about, you have the common iliac, the internal iliac, and the external. And then you can picture the groin being right here. This is then going to be the common femoral. This is the deep femoral, or the profunda femoris, or the superficial femoral right here. And the superficial femoral is going to continue down the thigh, and as it reaches the level of the knee, right about here, it changes its name to popliteal artery, and then the popliteal artery is going to split into anterior tibial, posterior tibial, and a smaller middle part called peroneal artery. This is also called the fibular artery. So peroneal and fibular are synonymous. But what's important is if you look on the right side here, this posterior tibial artery, so this one right here, posterior tibial artery, is going to curve on the inside of the foot, so by the medial malleolus and underneath the foot, to supply the underside of the foot all the way out to the toes and make an arch right here, connecting to the anterior tibial artery, which comes here. The anterior tibial artery is going to continue on the dorsal side of the foot and make the dorsal pedis artery, the one you palpate. So when you palpate pulse on the foot, you're going to place your fingers right around here to palpate the posterior tibial artery, and you're going to place your fingers right around here to palpate the dorsal pedis artery. And this is important to recognize, that the posterior tibial artery is going to make or continue on underneath the foot. The anterior tibial artery is going to continue on top of the foot, and together they make up this arcade, this network on the foot. So if we look into detail on the foot right here, on the left side you are looking at the foot from underneath, so the plantar part, the inferior view, and on the right side you're looking at from above, so the superior view. And if we look at the below, this is the posterior tibial. This is where it comes in, so it reaches all the way on the inside and goes underneath the foot and becomes a lateral plantar on the outside here, and becomes a medial plantar. And if you notice, the medial is going to cover this area right here, the lateral is going to cover this area right here, and together they make up a network towards the toe, all five of them. So If you look at the superior view on the right side, you see that the anterior tibial artery right here is going to continue and change its name to dorsal pedis artery. And that's going to supply most of the area on top of the foot right here. And this is significant because if we go to the next slide, it mentions the angiosomes. This is a concept that was introduced in 1987. It was published in a journal for plastic surgeons, and it's been debated for about 30 years, because what this shows is the angiosome, and the angiosome is think of it as a three-dimensional block of tissue that is supplied by a specific artery. So, like we said, if you look on the underneath the foot, on the left side, this is underneath the foot. You can see that picture that the posterior tibial artery will come right around here and split into the medial plantar artery right here and the lateral. And this part of the foot is supplied by the lateral and this by the medial. And on top of the foot, you have the dorsal pedal artery, or the dorsalis pedis, and it splits into branches right here. So if we go back, you might take a look at those two drawings and compare them, and you'll see how this idea of angiosomes is relevant to the circulation of the foot. And this is also shown that in some material, in some research being done, one has found that targeting or trying to open up specific arteries leading to that specific angiosome that has the wound has shown some promising results. So that's important to keep in mind. Now we're going to talk about disease development. So first of all, we have to talk about the pre-stage, or the atherosclerosis. And if you Google online, you're going to find that atherosclerosis means a disease, but to be more specific, atherosclerosis is just the hardening of the artery. It means plaque development. And atherosclerosis in itself does not give the patient any symptoms, or the person any symptoms. This is a process that continues throughout life. And what happens if you look, and this is kind of important to notice, this is a normal vessel. It has a smooth, nice inner layer, the tunica intima with the endothelium, and it has a normal muscular layer in the middle, the tunica media. But as we move along, smoking, high cholesterol, diabetes mellitus, and hypertension are by far the most important risk factors and the modifiable risk factors. And smoking, by far the most important. Stop smoking to slow down this process. Because what happens is you get an inflammatory process in the intimal layer leading up to fatty streak. I'm not going to go into detail, but I just want you to realize one thing, and that is that the intimal layer, as you can see, is you have a reaction, and it creates buildup, and eventually you'll have what's called a fibrofatty plaque. So cells from the muscle layer right here are going to migrate into this, and along with inflammatory cells and also fatty debris such as cholesterol is going to build up and make a big plaque, and that's going to narrow the lumen right here. So the opening is going to get narrow compared to what you had over here. And this is a process that continues on from about in the 20s, so it's happening in our body as we speak, but usually it's very slow. But especially smoking is going to speed up this process immensely. So here's a detailed overview, and what you see is that this is usually from the first decade, so about 20s to 30s, and usually the plaque is significant when when you get into your 40s or 50s. So that's people who have genetics that make them very predisposed to heart disease might have their first infarction, heart attack when they're maybe 40, 50. If they smoke and they have a genetic profile that says so. So if we look at the arterial insufficiency, now we're starting to talk about the disease development, and we have 4 stages of arterial insufficiency, stage 1 through 4. I've added stage 0 here because you can call atherosclerosis in itself stage 0, because this is the change or the stiffening of the intimal layer or the endothelium, and also the buildup of plaque. So in the beginning you have no significant narrowing of the artery, and if you do an ankle brachial index, there's probably not going to be any change in the foot, or I mean in the lower extremities. So you might have some narrowing here and there and some stiffening of the arteries, but no clinical signs of arterial insufficiency. The most important here is to have a healthy lifestyle, abstain from smoking, control cholesterol, and so on. And then we get into arterial insufficiency stage 1. That's when the narrowing of the artery becomes significant. So the patient might complain of intermittent claudication, meaning that they will feel pain in their leg as they move around. So if they walk maybe 500 meters, they'll tell you, or they'll tell their friends that, I have to stop because I feel pain in my leg. And that is because these narrowing arteries, so the plaque buildup is so significant that when they increase the blood flow to the legs, or they try to increase the blood flow, they are unable to do so, and the leg will demand more circulation, and when the leg can't get more circulation, they will feel the pain. At this point, it's important that we don't jump straight to surgery or intervention. So it all depends on how far the patient is able to walk and how much of a potential they have to build up collateral circulation. So circulation that bring blood down towards the lower leg and the foot without using the main arteries that have now become narrow. So you might have a low ankle brachial index, let's say 0.7, and the patient might say, I can walk 400 meters, but I have to stop, and this is painful, and it gives me somewhat of a decreased quality of life. And what we do is we give them best medical therapy, which includes cholesterol lowering medication and antiplatelet medication. And we tell them to exercise because this is not dangerous. We're not talking about the heart. This is not angina. So you're not going to cause a heart attack in your leg. What you're doing is you're opening up your collateral. So we'll talk about that later. In some instances, if the patient can only walk, let's say 30 meters or 20 meters, then they might not have the potential to train themselves out of this problem. And we might need to do intervention or surgery. Usually intervention is the first option. Stage 2 of arterial insufficiency is when the stenosis or the occlusion of when you have a stenosis or a significant stenosis that might lead to an occlusion of an artery, you most definitely have a decreased ankle brachial index. The patient has pain during rest, meaning that even the lowest demand during rest of the muscle is not enough. So the supply does not meet the demand even at rest. Then you have to do some sort of intervention or surgery. If not, you're going to go into stage 3 and you're going to have a wound develop. And some patients don't even have measurable ankle brachial index at this point. So you might have a wound, and if you're not able to measure the ankle brachial index, that means your main artery supply is compromised. and this is definitely a reason to do interventional surgery. And finally, stage 4, you have at least one or several occluded arteries. You might not be able to measure the ankle brachial index, and you have necrosis. So you have complete tissue loss. And in this case, most definitely interventional surgery and sometimes even amputation. And on this slide, I've simply colored it in. Stage 0 or atherosclerosis, no clinical signs. In stage 1 of arterial insufficiency, it's usually enough to exercise and give proper medical treatment and stop smoking. Most importantly, stop smoking. Stage 2, 3, and 4 are considered critical ischemia, so lack of arterial circulation. That is called critical. So if a patient has pain during rest, sleepless nights because of pain in the leg, then that's most definitely a reason to do something. Collaterals. We're going to talk about the collaterals. And collaterals means that the main artery, so let's picture this being the main artery of this person, and you can tell that that artery is sufficiently open so they don't need these sideways right here, these detours. They're fairly small. But in a person that has atherosclerotic disease, this artery is probably, it has been narrowing for years and years and years. So these sideways, these detours have opened up more and more because they have to participate in the circulatory or the delivery of circulation towards the lower leg and the foot. So what happens in a patient that has no collaterals, so this guy over here has no collaterals or no large collaterals. So if this is occluded right here, that person is going to have severe pain, acute severe pain. Whereas this person over here, if this finally occludes, they might not feel a huge difference because they have large collaterals. So we often see patients that have occlusions without having severe symptoms, if this has been going on for decades. So now we look at the examination. How do we approach a patient that we think has arterial insufficiency? Well, it's important to gain a detailed history of symptoms and look at the wound development. This session or this course focuses on wound treatment and the wound development due to arterial insufficiency. So I'm going to assume that this patient has a wound. So I'm going to ask the patient detailed history of symptoms, looking at intermittent claudication, how long has the patient been smoking and so on. And when did how did the wound develop? Was there a trauma? Is it simply a wound that won't close, or has it spontaneously opened up? Secondly, other illnesses, heart disease, any blood clotting problems, any immobility, obesity, so on. And especially diabetes mellitus. I'll get back to that, but that is especially important. Ask about the use of tobacco. Tobacco increases many-folds the risk of wounds. And then I palpate pulses. I would like to register the femoral artery, the popliteal artery, and the distal arteries. And by distal arteries, I mean the pulse on the back of the foot, the dorsal pedis artery, and also the posterior tibial artery by the medial malleolus. Finally, I measure the ankle brachial index, which is our go-to non-invasive test. You can also do a toe brachial index. I'm not going to get into depth about the toe brachial index. And you can also do transcutaneous oxygen measurements. And that's what's being done in this picture right here. Here you have the measurement of toe brachial index, and also these electrodes are placed to look at transcutaneous oxygen measurements. These are not typically available in your general surgery department or smaller outpatient clinics. So when should you suspect arterial insufficiency? Well, if the ankle brachial index is below 0.9 or if it's above 1.3. We're going to talk about diabetes mellitus, and in patients with diabetes mellitus, usually the ankle brachial index will be really high because they have you're unable to sufficiently compress the arteries to get a sufficient ankle brachial index, or at least a reliable measurement. Also, you should suspect arterial insufficiency if you have a wound with no palpable pulses on the foot, and especially if there's no palpable pulses in the groin, so the femoral artery, or behind the knee, the popliteal artery. And the typical clinical development is going to be that the patient will tell you, I had intermittent claudication, so I could walk 50 meters, and then I had leg pains, and then that developed into pain during rest, and I had wound development. That's a classical, the typical clinical development in a person with arterial insufficiency. Finally, I'm going to mention again, patients with diabetes mellitus are at high risk of serious tissue loss, and smokers with diabetes mellitus, very high risk. So you should, that in and of itself, a smoker with diabetes mellitus if that patient develops a wound, that in itself should trigger the investigation by a doctor or a vascular surgeon. So wounds that have not healed for at least 4 to 6 weeks of conservative treatment. This is usually the consensus among clinicians, that if you have a wound that has not healed for at least 4 to 6 weeks of conservative treatment, then one should look into the arterial circulation. Wounds that worsen despite of good conservative or topical treatment, such as steroids, should also look into the arterial circulation, and especially wounds that worsen when using compression stockings. Wound development in a patient with diabetes mellitus and no trauma to the skin at all should be a priority. I know from my experience that when it comes to wound development in a patient with diabetes mellitus, the development can be extremely rapid. So we're talking wounds on toes that develop into a major amputation within weeks. So what do we do if we suspect arterial insufficiency as a cause for the wound development, and we have some imaging techniques that we use. Our go-to is usually MR angio, and I'm going to show you a picture of an MRI or an MR angiography on the next slide. We can also use a CT. That depends sometimes on how we're going to approach the problem. So that's usually a debate left to the clinicians. But we also have digital subtraction angiography, and that's what you see on the right side here. And that's where you have a direct puncture, where we make a puncture with a needle in the femoral artery, and we can guide ourselves using angiolab. We can guide ourselves using the contrast material injected directly into the artery, and film. This is a dynamic test as compared to MRI or MR and CT. Those give us images that are unchanged, and we can look at them afterwards. But with a DSA, we can do intervention right there on the spot, but it's an invasive test. So we will puncture the femoral artery, we will inject contrast material, and that's what you see here. The contrast material will flow down the posterior tibial artery underneath the foot, and it will flow here anterior tibial on the dorsal pedis, and they will meet in an arcade down here. And finally, we can use ultrasound. The problem with ultrasound, although it's fast and it's cheap and it's more readily available, it's really hard to evaluate large areas. So it's really hard to evaluate from the abdominal aorta all the way down to the foot, because it takes some skill, and also it's time consuming, and not all hospitals have that ready on a short notice. This is an MRI, or an MR angiography, and what you see is on your left here, it's pretty much the same picture as the one we had that I've placed on the right side. So take a look, you have the abdominal aorta here, and these are your iliacs, and you see a small lesion right there, small stenosis. And then you have the femoral right here, just like this. And then this is the knee, the popliteal region right here. And then this is the anterior. This is the posterior. And this is the fibular right there. Good. And then really shortly, I'm just going to mention thrombus versus embolus. The layman's term is clot. So you'll hear the word clot a lot of times. But we distinguish between a thrombus and an embolus in the sense that a thrombus is a narrowing that develops on site. So as you have a buildup right here of plaque, you will narrow the lumen, and this part right here is called a thrombus. It narrows the lumen on site. If this is released and starts flowing down, starts going with the blood flow, then we call it an embolus. An embolus is loose material that moves with the bloodstream. It doesn't matter if it's in an artery or a vein. You can have fat embolus, which is just fat molecules that fly around in your arteries or veins. You can have air embolus, or you could have embolus like this from a plaque with cholesterol and all the buildup of decades. And usually what happens when an artery occludes is you have a combination. So you have a thrombus right here, and then you have the loose material that is sometimes just normal content of the blood will try to move past this very narrow area, and it will cause a fresh clot right here. And this is what we call the thromboembolic event. So we usually use the term thromboembolic instead of dividing these two. An embolus in itself, so strictly embolus, will usually cause a hyperacute situation. So if it happens in the heart, you'll have a heart attack. If it happens in an artery to the brain, you'll have a stroke. If it happens in an artery towards the leg, you'll have an immediate immense pain and maybe a cold white foot, and you'll go to the emergency room. And in these instances, you won't develop a wound. So a thrombus and a thromboembolic event is what we're talking about in this section. So wounds are not caused by a single large embolus, and a significant embolus is always an acute situation. Finally, diabetes mellitus. Diabetes mellitus is recognized as a strong risk factor for peripheral arterial disease. In some data, as many as 25% of people with diabetes mellitus develop foot ulcers or foot problems. It's estimated that the increased risk of developing intermittent claudication is twice as high in people with diabetes mellitus, and even 8 times as high if they smoke. And an estimated risk of an estimated increased risk of peripheral arterial disease is 4 times as high in diabetes mellitus as in the population in general. In Scandinavian countries, diabetes mellitus occurs in about 5% of the population, but people with diabetes mellitus make up 50% of all patients that undergo major amputations, meaning leg or thigh amputations. Worldwide, it is estimated that about 8.3% of the world population has diabetes mellitus. Diabetes mellitus is a disease that affects the tunica media, meaning that you'll have high levels of blood sugar, and the sugars will glycosylate. It will deposit crystals in this area right here, in the muscle layer, making the muscles of the artery stiff and unable to compensate. And if you at the same time affects the inner part, narrowing the lumen. So you'll have a stiff artery much faster, and it will start narrowing, and you'll be unable to compensate for that. And this will increase the ankle brachial index, because this part will become so stiff that when you try to do an ankle brachial index, you'll get a signal even if you increase the pressure in the ankle to, let's say, 200 or 230. You'll still get a signal giving you an ankle brachial index that might be 2 or 3. So the ankle brachial index is useless, other than the fact that it gives you an indication that there might be sclerotic media, so media sclerosis or hardening of the medium layer here. The complications of diabetes mellitus on the macro level, macroangiopathy, is that this is similar to atherosclerosis, but it develops earlier in life, and also the collateral circulation is less developed. So this is much more. It's a trauma to the circulatory system, and the circulatory system has not been able to develop collaterals, which makes the narrowing of the arteries that much more severe. And also on the microangiopathy, you have these are especially the tissues that are susceptible to damage, namely retinopathy. So in the retina, in the eye, the blood vessels there will be damaged, leading to blindness. Nephropathy, meaning the arteries in the kidneys, leading to kidney failure, and the neuropathy. So the nerves, especially the nerves in the foot, in the skin, are going to be affected, and you'll have neuropathy. And you'll have something called neuroangiopathy, meaning a mixture of arteries leading to the nerves and arteries leading to the skin itself will be damaged, and the patient won't feel that he has a wound. He won't feel that he's stepping on a thumbnail or some sharp gravel making cuts. And this will develop into the diabetic foot, meaning you'll have a higher risk of infection, you'll have a higher level of blood glucose, which gives food to bacteria, and you'll have damaged nerve endings. So finally, recap: suspect arterial insufficiency when you have an ankle brachial index below 0.9 or above 1.3, and also especially if there are no pulses on the foot or higher up. Listen to the patient's history and look for typical clinical development, intermittent claudication to pain during rest and wound development. And my 2 cents is that people with diabetes mellitus and wound development should be prioritized, and especially if they smoke, it can develop fairly rapidly. So let's review the teaching goals. We have defined an artery and looked at the buildup of arteries. We have looked at the major arteries supplying the lower extremities, and now you know the importance of the circulation of these arteries and the theory of the angiosomes. We have looked at the development of atherosclerosis and especially focused on the modifiable risk factors. I mentioned diabetes mellitus as a modifiable risk factor. Well, the disease in itself is not necessarily modifiable unless it's caused by obesity, but trying to control your blood sugar and have the best possible treatment of the diabetes mellitus is important. We have defined arterial insufficiency and looked at ischemia and development of wounds and necrosis in the clinical staging. We have talked about the difference between the thrombus and an embolus, and we've looked at the difference between diseases affecting the intima, which is pure atherosclerosis, and the media, which is what you will see in diabetes mellitus. And hopefully you know now when to suspect arterial insufficiency.